Okay, so this section is the GI system, gastroenterology. Let's do this question. A 55-year-old man. I always highlight age and ethnicity and gender of a patient because it really helps guide me. A 55-year-old man comes to the physician because of progressive difficulty swallowing. So progressive dysphagia for 6 months. He has a 15-year history of gastroesophageal reflux disease. A biopsy of the lower esophagus is shown. Which of the following best describes the nature of this lesion? The reason I highlighted lower esophagus because I know upper esophagus is mostly made of skeletal muscle. Lower esophagus is primarily made of smooth muscle. Upper esophagus is squamous epithelium, and the lower esophagus epithelium can slightly transition, so it just helps me to what I'm talking about. Okay. Now, if this, and then when you look at the biopsy of this patient, so this should be a straightly simple question. So let's just do this. 55-year-old male, okay, has progressive dysphagia. Dysphagia is difficulty swallowing. Okay. Dysphagia, and he has GERD, gastroesophageal reflux disease. And then the biopsy of and then there's a biopsy of lower esophagus shown. Biopsy. What do I see on biopsy? On biopsy, I see this columnar cells, long tall cells. So columnar cells, if you pay attention to this picture, let me see. Okay, how do I know these are columnar cells? Okay, let me see if this helps. I'll make this picture bigger so we can see. There you go. Okay, so let's say this is picture A because I'm going to show another picture. In this picture, you can see these clear dots. These clear dots, like right here, the one I'm highlighting. Let me see if I can highlight it for you with green. These clear dots, these are goblet cells. So number one, I'm seeing goblet cells. Okay, I'm seeing goblet cells. Goblet cells are mucus cells. They're full of mucus liquid. So there's not much organelles and stuff. That's why you will see them like a bubble. Okay, so these are goblet cells. So that's one. That's what I see. And then I see right here. So let me highlight this part for you with red. This area. If you can see the cells in that area appear tall, and the nuclei in the bottom. So they're tall cells like this. Sometimes I can't see the margin of the cells, but I see those dots, the nuclei. That's what I see. Okay, so the nuclei are aligned in the bottom. These are columnar cells. The top is clear, the bottom has the nuclei, columnar cells. Okay, so I see columnar cells, column-like columnar cells. So these two, for me, these two are enough because this is not esophagus. Esophagus epithelium is this epithelium of esophagus naturally is made of squamous flat cells stratified, which means multiple layers of stratified epithelium. So the esophageal epithelium is stratified squamous epithelium. Okay, you should know that because it'd be very helpful. If I were to draw it, they'd be flat cells like this, not tall cells. Flat cells. And multiple layer of them. Stratified means layers. So multiple layers of stratified squamous epithelium. I'll show you a picture later on, a biopsy picture, but just for now know this. Look at the difference. These flat cells compared to the tall cells. So whenever I see goblet cells and columnar epithelium in the esophagus, I know this is not a natural epithelium of the esophagus. The natural epithelium of esophagus, which one? Stratified squamous epithelium, which is made of multiple layers of flat cells. So as soon as I see that, I expect this to be metaplasia. So my diagnosis would be this is metaplasia. Okay, so I know this is metaplasia. Now the biopsy shows what? It shows metaplasia. Metaplasia to what? Metaplasia means change. It means change in epithelium. It's a function of adaptation. Okay, so the esophagus is adapting to its environment. It has the natural epithelium of the esophagus is squamous, stratified squamous epithelium. Guess what? Stratified squamous epithelium cannot protect itself against chemical damage. Stratified squamous epithelium is primarily for physical damage. So when you eat food, it could be rough, it could be damaging, it can cause friction and erosion of the esophagus epithelium. That's why it has multiple layers. So there's not acid in the esophagus. Esophagus only for passage of food, not for digestion. But stomach is for digestion, chemical breakdown of food particles. That's why you have HCl in the stomach. So because we have GERD, in GERD there is increase in HCl, and this HCl with the lower esophageal sphincter being incompetent. So, and that's what GERD is, right? Gastric acid reflux disease, right? Gastroesophageal reflux disease. That means the acid in the esophagus, in the stomach, goes into the esophagus. Let's do this. Let's say this is the stomach. Here is the esophagus. Okay, and then the duodenum. Okay. I like drawing because you tend to remember stuff with drawings. So there you go, yellow stomach. And then we have, okay. So you have LES right here, which should be closed, which should be shut. It should be closed. But guess what? In this case, the LES is open. So acid goes into the esophagus. Acid refluxes into the esophagus, HCl. Stomach is designed for HCl. So stomach is resistant to HCl digestion or damage or irritations, whereas the esophagus is not designed for HCl or strong acid, like HCl whose pH and pK is 2, right? So therefore, the esophagus is not designed for that. The LES should always be closed and shut to prevent upward reflux of acid into the esophagus. But when the LES is incompetent, it doesn't close completely or doesn't close properly, the likelihood of acid going into the esophagus is much higher, and that's what happens in GERD. And this leads to chemical irritation and eventual inflammation. Okay, so this, at the end of the day, is Barrett's esophagus. But let's see what is the issue with GERD. Okay, so here I'm going to write it down for you. So what GERD will do, or acid reflux. GERD or acid reflux leads to esophageal inflammation. Esophageal, obviously lower esophagus, right? Esophageal irritation or inflammation, one and the same thing, whichever term you prefer. Inflammation. And the inflammation, recurrent inflammation, not one time, not two times, on daily basis for months and months and years, eventually will lead to metaplasia, because then your esophagus thing is like, look at this guy. Every time I fix my epithelium that is damaged by acid, this person keeps taking acidic food and again over and over, and the LES stays open, and I get and the epithelium keep getting damaged. So if that's the scenario, the esophagus says, you know what, this time what I'm going to do is I'm going to change my epithelium such that it can neutralize the acid. So therefore it changes the epithelium into, and change means what? Metaplasia, right? Change for epithelium is, the term is metaplasia. So then the epithelium, the lower esophagus, goes under metaplasia. It changes from squamous to columnar. Columnar epithelium, including with the goblet cells, produces a lot more mucus, which can neutralize the acid getting up into the esophagus. Okay, so this will be metaplasia. And when metaplasia occurs, we call it Barrett's esophagus. Barrett esophagus, right? Barrett esophagus. Okay, Barrett esophagus is nothing more than a change in epithelium. But Barrett esophagus is at a huge risk of transformation into dysplasia and eventually cancer. So whenever a patient has Barrett's esophagus, it is recommended that they get routine endoscopic surveillance to make sure that there is no dysplasia. So this metaplasia can eventually go into dysplasia. And dysplasia can lead to eventually to adenocarcinoma of the lower esophagus. Adenocarcinoma. Okay? Because by that point, the epithelium says, you know what, I'm not going to wait for the esophagus to replace me and change me. I'm just going to start producing so many cells, so much more mucus, and mitosis cannot be stopped, and the growth or mitosis is uncontrolled, and it leads to cancer. So that was the whole idea. GERD leads to irritation and inflammation of the esophageal epithelium, which can then adapt or go under metaplasia, called Barrett esophagus, and then Barrett esophagus, under further damage and so forth, can go under dysplasia and lead to adenocarcinoma. Good? All right, so that's our diagnosis. Our diagnosis at this point is, it is not so much carcinoma, it is Barrett's esophagus. So that's our diagnosis. Okay. If Barrett's esophagus is our diagnosis, then what does that mean? We have to look for an answer that reflects that. Let's go over the choices. Basal zone metaplasia. So let me change it to red. Basal zone hyperplasia of submucosal gland. Hyperplasia of submucosal gland can be sort of a cancer or increased growth, but that's not what it is. We're looking for metaplasia. B tells me intestinal metaplasia of squamous epithelium. Definitely that's the answer. So A is incorrect. Malignant transformation of epithelium into squamous carcinoma. No. The lower esophagus, especially in response to acid damage, does not become squamous carcinoma. Squamous carcinoma primarily occurs in the upper esophagus, and it's primarily caused by smoke, alcohol, and those kind of things. So lower esophagus will have adenocarcinoma. Upper esophagus, squamous carcinoma. Because in our question, what are we talking about? We're talking about in our question lower esophagus, right? We're talking about lower esophagus at the LEL level. That's what it says here. Upper esophagus. Squamous metaplasia of submucosal gland? No. Okay. So the best choice that explain is metaplasia of the squamous epithelium to intestinal epithelium. Intestinal epithelium is made of columnar cells with goblet cells. Okay, so our answer choice should be B, which makes the most sense. But again, the whole purpose of this question was for you to understand what is Barrett's esophagus, and that's our diagnosis, right? Our diagnosis is Barrett esophagus. Okay, and that should be good enough. Once we can diagnose that, Barrett esophagus, it has a specific meaning. All right, let's go to the next question. Oh, before we go to the next question, I want to show you something. Let me show you the natural. Okay, so here, this is the natural so this picture is a natural state of esophageal. So this picture B, this is squamous epithelium. Look at it. From top to bottom, there's many layers of squamous epithelium. So this is squamous epithelium. I should say stratified. Many layers of. How do you know many layers? You see these dots? That's each cell with each nucleus. So look, 1, 2, 3, 4, 5, 6. It's like 20 layers. Compare that to A. This was A. Huge difference. No goblet cells in B. No columnar epithelium. It's simple squamous epithelium with multiple layers. Okay, so that should be, you should be looking for that. Plus, in A, you can see like almost like a villi type of structure, right? There's those villi as well, which looks like intestinal. So always look for intestinal metaplasia of squamous epithelium when you talk about Barrett's esophagus. Okay, so the next question is, a 65-year-old man dies from a massive cerebral aneurysm rupture. Autopsy specimen is shown. Which of the following is the most likely diagnosis? So we want to know what his diagnosis simply based on the picture, because this person died because of a stroke, Now they want to know what's the cause. So what do we see? Let's label this picture A because I will show another picture, which is picture B. What do we see? We see liver. We see a structured liver, and the liver has multiple lesions or masses. Okay, the masses does not appear as if they are part of the liver, as if they came from outside, because look at the surrounding so there's sort of like an edema around the masses and there's no dominant mass. So whenever you see multiple masses within a liver surrounded by edema and swelling, and then you should think of metastatic liver cancer. Metastatic liver cancer. Okay. Now the question is, so this is a primary liver cancer, right? Metastatic or secondary liver cancer? Secondary means coming from somewhere else. Metastatic coming from somewhere else. What do we expect in a primary liver cancer? Primary liver cancer. So we can compare them. Primary liver cancer would be like hepatocellular carcinoma, right? Hepatocellular carcinoma. You want to compare it to these two right away in our head. Usually they would have a single dominant mass, even if there could be small other ones, but there's one major mass, single mass, and accompanied by signs of cirrhosis. Cirrhosis would be small nodules like dots, with a single large mass. Okay, I'll show you a picture. So look for those things. These things help us. We know that the cause of liver cancer, primary liver cancer, could be, for example, hepatitis B virus, could be hepatitis C virus, it could be alcohol, because alcohol can lead to cirrhosis, right? And then we can, in addition to, what else can we include in here? Okay, we're just talking about cause of primary liver cancer. Hemochromatosis, right? Hemochromatosis. All of these guys leads to cirrhosis. So the main issue is cirrhosis. Okay, and the cause of secondary liver cancer, number one, will be those cancers that are GI cancer, because liver is part of the digestive system. It's in the abdominal cavity. So cancer of the abdominal cavity or abdominal organs are more likely to travel to liver first. Such number one will be colorectal cancer. Okay. And then let's say pancreatic cancer, gallbladder cancer, and gallbladder just under the liver. So just because the physical distance, right? Gallbladder cancer, ovarian cancer. What else is the gastric cancer? Okay, once you pass with these, then you should be thinking of something like breast or lung cancer. That is after you have the GI cancer. So these are the causes of secondary liver cancer, colorectal cancer, for example. Okay, so these are causes of secondary or metastatic liver cancer. Primary cancer, hepatocellular carcinoma, hepatitis B, hepatitis C, alcohol, hemochromatosis, and so forth. Underlying cause, usually cirrhosis. Okay. All right. So from our picture, we know this one is secondary liver cancer. This is not a primary, so it's metastatic liver cancer. If it is metastatic liver cancer, then we look for the causes, right? We look for the causes in these options. Number one is acute lymphoblastic leukemia. Okay. Yeah, it could travel. but it's extremely rare for leukemia to leukemic cells to travel to where into liver. They could travel mostly to like lungs and brain. Colon adenocarcinoma, we said this was a really important cause, so we'll keep this one because that's the GI. Hepatocellular carcinoma is primary, so that cannot be the answer. So hepatocellular carcinoma is primary liver cancer. Leukemia is much less likely compared to colon adenocarcinoma. Leiomyosarcoma is cancer of the smooth muscle, uterus, and so forth. Unlikely. Liposarcoma is cancer of fat cells. Unlikely. It doesn't really travel much. Meningioma is within the brain. It's benign, so it doesn't even travel. It's not metastatic. Malignant melanoma, yes, it could, but not as much as colon adenocarcinoma. Renal cell carcinoma, yes, it could travel, but again, not as much as colon adenocarcinoma. Glioblastoma multiforme is metastatic, but it is within the brain, so it's unlikely, not as much as colon adenocarcinoma. So the best choice would be B, colon adenocarcinoma. We had in our explanation here is the most likely. The person's age is a good a good guide as well. Okay, so let's also look at this. So what do you see in this picture? In this picture you see a single mass, right? This one, single mass. Let me color it green so you can see. I'm going to color it green. I won't be able to color the green. Okay, so you see in this picture a single mass with a lot of dots within the liver. So this picture shows us cirrhosis and a single mass. This is primary cancer. So picture B shows us signs of cirrhosis, and then it also shows us a single mass. Okay, let me show you. See if we can enlarge this. Okay, now let's see if we can see this. So here you go. Let me highlight the single mass. This, the one I highlighted in green, this is the single mass. So this is hepatocellular carcinoma. Okay, and then you can see the dots within the liver. See, the liver is not homogeneous. It has dark dots and light dots. That's signs of cirrhosis. In cirrhosis, the liver will be always nodular, fibrosis in regenerated areas. Okay, so this was a good question. It's really a step 1 question. Hopefully this was helpful. Let's go to next question. Okay, so next question is a 48-year-old woman comes to the physician because of 6-month history of difficulty swallowing. So 6 months long-term, both solid and liquids. She has weight loss, about 12 pounds of weight loss during this time. There is no history of fever, chills, or pain with swallowing, so it's not infection or esophagitis. She is not sexually active. She does not drink alcohol, does not smoke cigarette or illicit drugs. She's 5'5", BMI is 22, that's okay, that's good. Vital signs are stable, physical examination is normal, barium swallow is shown. Okay, which of the following is the most likely explanation for the symptoms? Okay, so let's see what we see. What is our diagnosis? That's what they're asking. So a 48-year-old female or woman, doesn't matter in this case the gender, has dysphagia. This dysphagia is for 6 months, and it's to both solid and liquid. To both solid and liquid, right? Okay, and dysphagia accompanied by weight loss. Okay, when you hear a slightly older person, like in their late 40s and 50s, with dysphagia and weight loss, you should be thinking of, so that what is our differentials, right? The differentials should be we're going to think of the differentials, right? Our differentials diagnosis. And I'll tell you why I pick one or the other. Should be achalasia, should be esophageal. So this is lower esophagus in this picture. So you also have, in this case, we also have something else. You know what, let's just keep this for now. We have this endoscopy picture. So we have a barium swallow of the esophagus as well. So we think of cancer, esophageal cancer. So these are things I should be thinking about, but they're telling you in this question and you can think of esophagitis, but it's ruled out because the person has no fever, no chills, or no pain and swelling, so we rule out esophagitis. She's not sexually active, so that rules out, for example, like cytomegalovirus and candida and so forth. She does not drink alcohol, so that kind of rules out esophagitis, eventually leading to like cancers, right? So alcohol, do not smoke cigarette. Okay, so those are important things, sort of like giving clues that this is not cancer. And the weight loss, because weight loss will can make you think that this is cancer. The barium swallow for sure doesn't show it. So the barium swallow, what do I see on barium? But anyway, so we should be thinking of those, right? Then when you look at barium swallow, I see bird beak appearance. So imagine here it gets narrowed like this. Proximal esophagus is swollen and distal esophagus is narrow, and then you can just see a straight, very tiny line. Imagine I give an eye, and this is bird's beak. Okay. All right. So we see bird beak. When I see these four things now, before I was suspicious achalasia or cancer, but when I add the fourth one to it, now I know for sure this is achalasia. I'm done. So this is achalasia. Okay. So for me, this is achalasia 100%. Now, the question they're asking is, what is the cause of achalasia in this person? Is it acid reflux? Is it atrophy? It's this and that. So the cause of achalasia, okay, so what is achalasia? Let's talk about what is achalasia. Achalasia is degeneration of myenteric plexus of the esophagus. Okay, so achalasia is chronic inflammatory degeneration of myenteric plexus. The myenteric plexus is the nervous system within the esophagus, right, or the entire GI. This leads to two things: defective peristalsis, or abnormal or deficient peristalsis. Number one. Number two, this leads to increase LES tone. So increase LES tone. So LES tone is increased such that the LES doesn't open. It never opens. It fails to open. Okay, it fails to relax. So there's impaired relaxation of the LES. You can use that term, impaired relaxation of LES. ELS never relaxes. It's always tense, tight, with increased pressure. And such that if I do manometry, and then they show you this is the normal LES. So let's say we label this LES, normal person, and the person with achalasia, it will be this much. The tone is increased. So this is achalasia. Okay, so look at the tone. It's much higher. Tone is increased. Okay. So two things you should use to diagnose achalasia. Number one, barium will show you bird beak, and then is manometry, which measures the pressure within the esophageal muscle. Okay, and that will show you that LES tone is increased and peristalsis is abnormal, the wave of peristalsis. So those are the things. Now that we know this is achalasia, let's look at our choices to see if there is a choice. Acid reflux into the lower esophagus, that would be GERD. Atrophy of the smooth muscles in the esophagus. Atrophy of the smooth muscle of the esophagus. If the smooth muscle of the esophagus is atrophied, that will be like in fibrosis, such as maybe scleroderma. Inflammatory degeneration of the esophageal wall neuron. Yep. Inflammatory degeneration of the esophageal wall neurons. Neuron is the myenteric plexus, so I'll choose that for now. Longitudinal muscle tear at the esophageal junction, that is Mallory-Weiss. Perforation of the esophagus, that's Boerhaave. Okay, so now I can tell you it's not A. The choice A is not correct because A is GERD. In GERD, you have acid reflux into esophagus, reflux. I'm forgetting the F, but you can add it. And this will give you burning chest pain, right? Burning chest pain. That's what it's famous for, burning chest pain, which is positionally can lead to chemical asthma and so forth. And you give them antacid, it should resolve. Okay, so they have the incompetent LES. In the case of acid reflux disease, the LES tone is actually decreased. It's more relaxed. It's not increased. So it's the opposite of achalasia. Achalasia is the LES is super tight, increased tone. Whereas with GERD, it is loose. It doesn't close completely. It's incompetent. Atrophy of the smooth muscle of esophagus. I'll think of scleroderma. Okay. In scleroderma, you should have thick, shiny skin. Okay, so they can have restrictive lung diseases, difficulty swallowing, dysphagia will be there, and you can have skin problems, lung problems, and esophageal problems. Those should be helpful enough. Okay, C was our option. Okay, let's look at D, longitudinal tear in the esophageal gastrojunction. So if this is the stomach, this is the junction, so there is a linear tear right here in the esophageal wall. This is called the Mallory-Weiss tear or syndrome. Mallory-Weiss tear occurs because the esophageal mucosa is very sensitive. It's only a mucosal tear. Remember that it's not like smooth muscle. The esophageal mucous membrane is super sensitive, even though it's multi-layer, but repetitive retching and vomiting can lead to damage and tearing, and it can lead to bleeding. So the main issue here will be vomiting, blood-stained vomitus or vomiting blood sometimes, and pain. Okay, so chest pain with vomiting blood, not coughing, vomiting. Okay, so the next one is perforation of the esophageal wall. This is Boerhaave syndrome. Okay, in Boerhaave syndrome, the esophagus completely ruptured. It's not just a tear. All three layers of the esophagus, mucosa, muscularis, and adventitious, they're all torn, such that it can lead to mediastinitis, chest pain. Mediastinitis means the gastric content can go into the mediastinum. It can cause inflammation around the heart and lungs, and can cause pneumomediastinum. Air can enter the mediastinum. Pneumomediastinum. So look for those things. Okay, it'd be sudden onset, severe pain in the chest, tearing chest pain, accompanied by mediastinitis and mediastinum. Pneumomediastinum. Yeah. And Boerhaave, again, it's common in people that are drinking and usually drink alcohol, so they can lead to this tremendous vomiting, forceful vomiting. It's the forceful vomiting that can damage the esophagus, or sometimes endoscopy. Some people who are not well trained in endoscopy, so it's also iatrogenic damage to the esophagus. Okay, let's do our next question. Okay, a 49-year-old woman comes to the physician because of 6-week history of dysphagia, halitosis, regurgitation of undigested food. She has no fever, chills, or pain with swallowing. A barium swallow study shows a 6-centimeter posterior midline diverticulum protruding between the thyropharyngeus and cricopharyngeus muscle. Okay, these muscles are most likely innervated by which of the following. Okay, so this question is about two-step question. First, they want you to diagnose it, then they want you to know the muscles that are involved in this scenario are innervated by what. Let's diagnose it first. Okay, so when we have, age is important because this condition is, let's say, 49-year-old woman. So there you go. And then we have symptoms of dysphagia, halitosis, and then regurgitation of undigested food. Sounds like achalasia, but let's see. Regurgitation of undigested food. Undigested food, which means food never went to the stomach. It's undigested, right? So whatever is the issue, food doesn't go beyond esophagus most likely. That's why they're telling you undigested food. And there is a 6 centimeter posterior midline diverticulum. So there is a diverticulum, which is an outpouching or a sac, you can say, protruding between the two muscles of the esophagus. So in this diverticulum is posterior. Okay, so it's posterior. A barium swallow shows 6 centimeter posterior midline. In its midline, it's in the middle, between the two muscles. Cricopharyngeus, the thyropharyngeus and cricopharyngeus muscle, you should be thinking just in your neck, just below your chin. That's where you have your thyroid, so in that area. So the diverticulum is posterior, not anterior. Okay, so obviously it's esophageal diverticulum, but when I hear these things, first of all, when I hear 49-year-old, dysphagia, halitosis, regurgitation of undigested food, let's say we include also weight loss, I'm going to think of achalasia. But they're telling it's posterior diverticulum, so I'm not going to think of achalasia anymore. So this is diverticulum. The upper esophagus is called is Zanker's diverticulum. Yes, Zanker's diverticulum. Okay, so Zanker's diverticulum. Why did I say A? It's with E. Zanker diverticulum. That's our diagnosis. Diverticulum. Okay. Zanker diverticulum it occurs. The pathology is actually weakness in the posterior. It's a cricopharyngeus muscle weakness. So the muscle become weak, and then the diverticulum can just form through that weak area. Risk factors for that is, risk factor will be with aging. As you get older, muscles get weaker and so forth. Plus frequent infection, sore throat, right? Frequent sore throat or pharyngitis. Maybe you can include in this his Marfan syndrome, Ehlers-Danlos, those connective tissue diseases put you at risk as well. So you can think of those things. Polycystic kidney disease puts you at risk. Just think along those lines. So we know it's pathology, we know it's risk factor, and then the symptoms are already given to you. Difficulty swallowing, halitosis, bad breath, regurgitation of undigested food. Now the regurgitation doesn't occur, it's positional when you lay down, or because gravity will pull when you're standing. So when you're laying down, then usually you'll have this regurgitation. So it's positional regurgitation. Okay. Obviously, if you want to test for it on barium, you will see. Barium is a good test on barium. You will see, let me see if I were to, let's see right here. No, there's a hole somewhere. Let's see where. Okay. So what would you see on barium? Generally speaking, the esophagus starts here and it goes, and then it goes to stomach. Okay, so let's see the stomach. If the stomach is full of the barium, then it will glow white. The esophagus will glow white. But then right in the upper esophagus posterior there you will see like this pouch. So this is the diverticulum. Let me use red so you can see. This is the diverticulum. Okay. All right. Okay. Assuming, so this is the oral cavity, the chin, mouth, nose of a person, eye. Okay. All right. All right, so that's what we'll be looking for on barium. That's what we'll see. Now let's go back to the question. The question saying is, what nerve innervates these muscles? So these muscles are obviously muscles of the pharynx, pharyngeal muscles. Pharyngeal muscles is easy to memorize. Almost all of them, all pharyngeal muscles, all are innervated by vagus nerve, cranial nerve number 10. Cranial nerve number 10. Okay, except one, except one muscle, okay, which is the stylopharyngeus. Stylopharyngeus muscle, which is innervated by glossopharyngeal. Okay, glossopharyngeal is cranial nerve number 10. Glossopharyngeus. Glossopharyngeal nerve, in this case, is cranial nerve number 9. Okay, so the two muscles we're talking about are cricopharyngeus and thyropharyngeus. So those are both by the vagus nerve. So we're going to look for vagus nerve. Sensory fibers of the glossopharyngeal nerve? Nope. Remember, we said glossopharyngeal nerve innervates only stylopharyngeus, so that's not it. Motor fibers of hypoglossal nerve, that supplies the tongue. Motor fibers of vagus nerve? Sure. Sensory fibers of vagus nerve? No. Sensory fibers of vagus nerves are more for the GI tract, the mucus glands, and so forth. Sympathetic fibers, superior cervical ganglia. Superior cervical ganglia is right at the top of the lung, the apex of the lung, which is involved in the Horner syndrome, right? So think of those things. Parasympathetic fibers of pelvic splanchnic nerves supplies. Okay, so all of the GI tract is supplied by vagus nerve up to the 2/3 of transverse colon. After the 2/3 of transverse colon, the rest of the GI tract is supplied by pelvic splanchnic nerve. So that would be supplying the colon, transverse, distal 1/3 of transverse colon, descending colon, rectum, and anal canal, and so forth. So the answer should be motor fibers of the vagus nerve. There you go. Okay. All right. Again, this is very typical step 1 question. You should always, guys, you should always think of this. All pharyngeal muscles are supplied by vagus nerve except stylopharyngeus, which is by glossopharyngeus. Okay, so next question is, an 80-year-old woman comes to the physician because of chronic fatigue. She has had long history of constipation, anemia, decreased energy. Her diet includes red meat, fish, chicken, pasta, rice. Not much vegetables, right? She lives alone since her husband died 20 years ago. Laboratory results shows iron deficiency anemia. Her stool test is positive for occult blood. Colonoscopy shows numerous diverticuli. The diverticula in this patient are most likely present in which of the following colon region? Oh, this is more of an anatomy question. Okay. they're simply asking what's the most common location. So most common location of colon diverticuli. Diverticulus is one, diverticuli is none, right? The most common location, just strictly memorization, is rectum. Rectum. Do we have rectum here? If you don't have rectum, then it will be sigmoid colon. Next one, yep, we have that. Okay, so let me go over this. Ascending colon, no. Cecum, no. Descending colon, no. Transverse colon, no. Sigmoid colon, yes. Sigmoid colon. Okay, there's few reasons for that. The reason sigmoid colon is the most common location is because sigmoid colon, number one, by the time stool or digested food reaches this, most of the water is reabsorbed, and it's in the sigmoid colon and rectum it's more solid. Okay, so it can push against the wall of intestine. It makes it weaker because of erosion and friction. Number two, in addition to that, sigmoid colon is slightly narrow, so the pressure there is much higher than transverse colon, ascending and descending colon. Okay, plus stool can pile up there as well, right? That's that's the distal end of the large intestinal colon. So multiple reasons. Number one, its lumen is narrow, so pressure is high. Stool pile up, and stool is hard in that region because most of the water is reabsorbed in the rest of the intestine. So for those reasons, it's much more at risk of diverticulosis. And diverticulosis is nothing more than weakening in the wall of a colon, and it like balloons out or makes a sac or punches out or outpouching, whatever they call it. Okay, so look for those things. Now, our diagnosis is diverticulosis. Diverticulosis. Okay, so who is at risk for diverticulosis? Number one, almost 80% of the patients are 80 years older. 80 years and older. So what I'm saying is older than 80 years old, and especially female. More common in women than men. Okay, so it's age related. Plus, who else is at risk? Chronic polycystic kidney disease, Ehlers-Danlos. What's the other one? Marfan syndrome. Marfan patient could present at a young age. Okay, so look for those things as well. Okay, and if that is the case, so let's say this is colon. Let me draw a colon. And here is an outpouching, let's say. And what do you see on barium, right? Let's close this down. On barium. So on barium, what do you expect to see? Oh, there's a hole somewhere. Okay. Okay, and that's what you will see on barium. But now the diverticulosis would appear like this. Many outpouching in the intestine, right? Like that. So there's air that are weak. Okay, so what's the big deal? Well, hard stool, let's say there's hard stool coming from the inside. The hard stool, let's say in this case it is slightly gray, it's going to push. When it pushes on this, and it can lead to erosion and bleeding. And then of course there'll be bleeding. That's the most common symptom in these cases. So the most common symptom of diverticulosis is bleeding. Loss of blood, hemorrhage, right? Lower GI bleed. If it's bleeding, that means low iron, so this leads to iron deficiency. Anemia. Iron deficiency anemia on peripheral smear is always microcytic, hypochromic, chromic, red blood cells, or you can call it anemia. Okay, so look for that. And of course the sign of anemia are fatigue, pallor, pale skin. It depends on the severity. Eventually can lead to murmur, chest pain, dyspnea, and so forth. So we have chronic fatigue, that makes sense. The constipation, because constipation is a huge risk factor. Okay, constipation is a huge risk factor for diverticulosis. In addition to that, of course, what else? Low fiber diet. Low fiber diet. Okay, so this person is primarily eating red meat, fish, chicken, pasta, no fruit, no vegetables. Low fiber diet is a huge risk factor. Red meat is a huge risk factor. Constipation is a huge risk factor. Age is a huge risk factor. Women are a huge risk factor. Okay, so look for those things. And the symptoms will be, of course, history of constipation, but the history is because of bleeding, so it'll be anemia and fatigue and low energy. Okay, so hopefully this was helpful.